You have to release it to me. I'm sorry, Mo.
Okay, that's fine. We're on. Welcome again, everyone, to the November 2019 Fresh School Health and Nutrition webinar. This is Mohini Venkatesh from Save the Children, and I'm joined by my colleague Solome Aceris. And we'll be presenting to you the Fresh uh, webinar with colleagues from the Global WASH team at Save the Children as our presenters this month. Just a little bit about the Fresh webinars and Fresh itself. It's an interagency partnership for school health and development in low and middle income contexts. And as a community of researchers, practitioners, and policymakers in education and health, we host monthly webinars on topics related to children's health and well-being. This month, we're celebrating World Toilet Day, which is on Tuesday, the 19th of November. And for today's webinar, we're looking at wash behaviors among school-age children and the role they play in and out of school, and the tools and methods that can be used to engage them, and the incentives that some of our programs have used in encouraging positive behaviors and using and listening to children's voices in the design and construction of toilet infrastructure. Now to presenting our speakers. We have our first speaker is Steve Serra, who is a member of the SAVE US Water and Sanitation and Hygiene team. He's been with the team for the past 5 years and focuses on WASH to support improvements in maternal, newborn, and child health across Asia, Sub-Saharan Africa, and Latin America. He has 8 years of experience working in global health and international development and holds a bachelor's degree in history from Purdue University and a master's degree in global environmental health from George Washington University. Steve, welcome. Um, our next speaker is Abraham Varampat, who is a humanitarian and development WASH professional with over 19 years of experience in various national and international agencies, including Oxfam, UNICEF, and since 2010 at Save the Children. Abraham has been deployed across more than 25 countries in Asia, Africa, the Middle East, Latin America, the Caribbean, Southeast Asia, and South Asia. So loads of experience in the room. Um, and Abraham, welcome. Abraham and Steve, I'll hand it over to you now. And Steve, if you can get us started. Thank you.
Sure. Thanks everyone for joining. I think this might be a little bit different than most of the fresh webinars in that we're going to focus a little bit outside of schools. And my presentation is going to start with more of like a thought-provoking presentation that's focused on a problem that we've seen in some of our programs recently, or has bubbled up to the surface of some of them. And then after I speak for a few minutes, Abraham will
Welcome.
present we'll present about a few of the concrete innovations that SAVE has been working on. So, so I'm going to start with discussing how we are thinking about approaching school children as caregivers within child stunting reduction programs. And this is a problem, as I said, that's sort of bubbled up in our recent child nutrition programming. And so I'm going to basically pose the problem and then also pose questions for all of us to consider in future work. Can you move to the next slide? Thanks. So typically, you know, we approach children ages 5 to 18 as they should be, as school children. And, you know, we want their main priorities to be attending school and excelling in their education. But unfortunately, in their lives outside of school, many of these children often have very burdensome responsibilities that we can't really ignore. Next slide. So this is a graph from a recent UN report, and it highlights results from a survey of working mothers. And we should recognize that global efforts are encouraging more women to participate in formal income generating activities. But we have to consider then who's watching the children when both parents are at work. We don't want to discourage men or women from participating in income generating activities, and another problem arises, right? So maybe we can pay particular attention to the third column here, which shows the percentage of children that are being looked after by another female child. As you can see, it's much higher percentage among the poorest households. Next slide. And so, you know, we should think about who's commonly providing care to children when their parents are both at work. There's typically four big types of other caregivers. One is organized care, so in a school or a nursery. Grandparents, especially grandmothers, children or other siblings, and then paid caregivers, so like a nanny service or something like that. Next slide. So there are a few impacts of caregiving responsibilities on school-age children. The first is that female children are much more likely to be burdened with caregiving responsibilities than their male counterparts. Caregiving can be for elderly or sick family members or for younger siblings. I'm only going to focus on younger siblings for this presentation, but there's also a huge burden put on children in terms of caring for other types of family members. And school-age children with childcare responsibilities are less likely to attend school, or they miss school more often. Next slide. And we have to recognize that there's some potential also for approaching school-age children as caregivers to their younger siblings, because although there's limited evidence, we do have some evidence that shows that children can be agents of change within their household and communities, and they can influence them to increase uptake of safe and healthy behaviors. And beyond this research, we know it's common for young children to mimic or copy their older siblings. So their older siblings are important models for younger siblings and the behaviors that they develop. So to sort of contextualize a little bit of this, I'm just going to highlight the importance of caregivers in child stunting reduction programs, which are some of the programs I typically work on at Save the Children. Next slide. So first, I think it might be important just to quickly review what stunting is. So it's the impaired growth and development of children. And they experience this from poor nutrition, repeated infections, and inadequate psychosocial stimulation. So really, it's a variety of sectors coming together that need to help solve this problem. We know that nutrition interventions alone, such as early and exclusive breastfeeding, diet diversity, they can really only make up 1/3 of the child height deficit that we see in stunted children. So WASH is important, family planning and birth spacing is important, maternal nutrition is important, and so is early child development. And we know that stunting is a problem that if children are stunted at 2 years of age, stunting cannot be reversed, and it impacts children for the rest of their life because their physical and cognitive development is permanently reduced. So it has impacts on learning, on economic productivity, and on social interactions forever. So it's a very important problem to focus on. Thank you. So the pathways linking WASH to nutrition outcomes, this is a slide from the World Bank, and it basically shows sort of like an update or a more detailed version of the F diagram. And what I'd like to just focus on for a second are the vectors. So these vectors are all things that caregivers have to manage in some way so that we can break the pathways and achieve the outcomes that are listed on the slide. So caregivers have to be able to ensure that, the household has clean water, that flies and fields are managed well, so soil isn't contaminating the home or objects and food, um, that fingers of younger children are clean, and that fomites like toys are also clean. Next slide. And so um, in typical nutrition sensitive programming, we know um, that typical wash interventions, like having a hand washing station, uh, purifying water, and having a toilet or latrine, aren't enough to help reduce the level of infections that we're seeing in these under 2 children. Um, and 3 recent efficacy trials have sort of shown this to be true. So despite these typical wash interventions being done at high levels in households and communities, we still see high levels of contamination in the household where children are spending most of their time. And these young children still have high levels of infection. So we're starting to look at other pieces of the environment as potentially important pathways, things like keeping children off the ground and their play spaces clean, um, making sure that infant and child feces is properly disposed of, improved food hygiene. We think that food might be a pretty important contaminant when children start eating food around 6 months of age. And we know that the level of contamination in the environment is mainly driven by animal feces in the environment and not really by human feces in many cases. So confining or limiting animal contact within the household living space may be quite important. We also know that on the nutrition specific side, that sufficient and diverse diets are a requirement to ensure that children don't become stunted, and that maternal and adolescent nutrition is important. So in this regard, when we're thinking about school children, not only will they as caregivers have to help manage the diet of their younger siblings and the feeding practices, but they themselves also have to have good nutrition because many of these girls will become mothers, maybe even within the adolescent period. Next slide. So all of this is background information, but the point of this presentation is to really show that children who are providing or assisting with childcare are playing a critical role in the lives of their younger siblings. So the extent to which we can engage them to instill good caregiving practices may be quite important. And the things that we have to work on with them, along with their parents, the primary caregivers, are limiting contact with soil and dirty toys for under 2 children, safe containment of and disposal of, this should say, of child feces, hand hygiene after fecal contact and after feeding, as you see in the picture, food management, so making sure that food is properly heated, that a diverse array of food is given to the under 2 children so they get um, the proper nutrients from their food, but also the proper quantity, and trying to also limit contact with animals and animal feces in the home. Next slide. So some of the things we've been starting to consider in the design of our child nutrition programs for children under the age of 2 are things like how we engage school children in the design, implementation, monitoring and evaluation of these programs. So some things to consider are, first and foremost, we want to protect the rights of the school children so that they can attend school and that they aren't deterred from getting an education. So there's a bit of a conflict of interest here in that we want to make sure that school children are able to attend and fully participate in school, but we also have to recognize that many of them have these child care responsibilities. And even if they aren't the primary caregiver, they may be often assisting their parents in caring for children outside of school. We want to make sure that WASH infrastructure features in the home environment are such that school-age children can access and use them so that they can participate in some of these best practices for child care and that they can help limit the risk of infection in their homes. We want to ensure that they have the proper knowledge and the agency to fully participate in good child care practices. And we want to explore the motivation and barriers that school children specifically experience related to providing care to their younger siblings and assisting with child care. And then obviously, it would be a best practice in these types of programs to layer child nutrition programs where school health and nutrition programs are already occurring because if these children are receiving a lot of the school health and nutrition interventions that we commonly implement in schools, they would be better placed as child caregivers in the home environment. And then during implementation, I think that when we talk about approaching school children as caregivers, we're typically thinking about children who are ages 12 to 18, so the older adolescents who can really understand what child care practices are and how to best deliver that child care. And we want to think about determining the best method for engaging these older adolescents as caregivers, whether it's best to work through their parents and have them sort of cascade these best practices to their older children, or if it's best to somehow work with older adolescents directly in the way that they provide care to their younger siblings. And then with monitoring and evaluation, just assessing the impacts of child education and mental health on providing childcare. And then for children under the age of 2, assessing the impacts and outcomes of interest. So if we worked with older children to help provide better childcare to their younger siblings, will we see an impact on the health and nutrition of those under 2 children? And then learning from adolescents about their experiences providing childcare, the impacts that it has on their lives, and also on the lives of their younger siblings. Next slide. And quickly, just some remaining questions to consider are: how do we best engage school children as caregivers without discouraging school attendance and without limiting their rights to be children themselves? Child care can have quite a burden on children's time, time that's taken away from education, but also playing and just being children. And it can have a great toll on their mental health. Is supporting school-age children as caregivers effective? Does it have any additional benefits? Something that we're trying to explore. And then how do we best engage school children as caregivers, as I was just explaining on the last slide. So that's the end of my presentation. I know that it didn't have any concrete data to explore in programs, but I just wanted to highlight that outside of standard school health and nutrition interventions, we are faced with a lot of the problems, a lot of problems in home settings on how we engage school children And we have to recognize the importance that school children play in some of these other settings. So at the end of Claudio's presentations, we'll take questions, and I would look forward to hearing your reaction on the presentation and maybe any other questions we should be considering moving forward in programming. Thank you.
Thanks, Steve. I'll have to start this presentation with a couple of caveats. Number one is both these innovations in WASH were done in a humanitarian context. And the second one is that these were done in IDP camps and not specifically WASH in schools or any activity in schools. But we are looking at using both these innovations at the school level, and that's where I think it might have some relevance to this particular group, which looks specifically at school education as well as WASH in schools. So there were two problems we tried to address. The first thing is about slow or poor community engagement, particularly children. So we were looking at children between 5 and 12, and engagement of these children in sanitation. In sanitation, when I say sanitation in IDP camp, we're talking about construction of latrines. Do we really involve children and their caregivers, particularly children between 5 to 12? The second problem we were trying to look at is the poor uptake of hand washing with soap in an IDP camp situation or a refugee situation. So these two are the problems we were trying to look at through these innovations. So the first, next slide, please. So the first project, we titled it User-Centered Emergency Sanitation Design. It should have been children-centered, but then we also looked at caregivers. So it was User-Centered Emergency Sanitation Design. This is a bit about the methodology. We start off with an interactive survey, a digital survey. Then we deploy the survey. The analysis of the outcomes or the results of the survey is done again using a digital dashboard. Once we identify what we call the pain points or the problems with the latrine design or the use of latrines, then we sit down again with children and caregivers and look at what are the ideas they have to improve the latrine design or anything to do with sanitation. And then the last step is, of course, to go and alter the sanitation design or the activity. Next slide, please. So there were two pilots at the time when I made this presentation, but we also now have a third pilot from Ethiopia. So the two pilots, one was in Iraq, the other one was in Bangladesh. Iraq was a refugee context, Syrian refugees moving into Iraq. Bangladesh was a Rohingya context where Rohingyas from Myanmar moved into Bangladesh. And the third context was actually longer-term IDPs, or what we call protracted IDPs in Somali region in Ethiopia, which was just completed a couple of weeks ago. So I have no analysis from that yet. So that pilot also adds to this particular innovation. So in terms of the pilots itself, we followed the same methodology. We had a launch session. A launch session was where we met the children and caregivers and representatives from the community, the affected community, and discussed what we were planning to do, what the objective of the whole exercise was. Then we did the interactive survey with the digital tool. The third one, go back to the same group and do what we call a co-creation session. What means by co-creation is we are looking at the latrine design and the latrine activity and try to design with the community, the caregivers as well as children, on what are the improvements that can be done to the existing latrines. And the fourth step, of course, was altering that design. Then we did an interactive survey again with using the same digital tool to see if there was any difference. And then finally, to see if any further alterations are required for the sanitation facilities. And that would be the end of the project. We had an evaluation of the pilots as well. Next slide, please. So what does a digital tool look like? So we had three main things we were looking at. One is outside the latrine. And the illustration you see is actually an illustration of the existing latrine in the IDP camp. So all the facilities that you see in the drawing or the illustration on the digital platform is actually from the ground. So we convert photographs into illustrations. So the three aspects we look at. One is outside the latrine, second is inside the latrine, and the third one is hand washing with soap. So the children actually are able to look at this tool and click on which of these are the pain points for them, which are these elements within the latrine design that makes them or prevents them from using the latrine or makes it a little hard for them to use the latrine. So when they click on that interactive survey, it kind of records that click. So they can basically record three aspects which are problematic within the latrine design. So if you look at the corner picture, which are called pain points, it's like a heat map. So if you look at the red, yellow, and the blue, the red is one where the red is one where most of the children actually pointed at as a problem. It was a point. It was two things. One is the door itself. The other one was the door lock. And the second one, you see the steps. It was either very high for the children or it was slippery. And then you see the outside, which means the sanitation situation outside the latrine was not good. So it was kind of flooding. There were too much garbage around the latrine, etc. Next slide, please. Now, I'm not going to details about the digital tool much more, but I wanted to really share within the time we have the findings from Iraq and Bangladesh. The Ethiopia one, as I said, is still being analyzed and will contribute to this project further. If you look at the children's satisfaction with latrines before, the first interactive survey within the methodology, we used basically smiley scales with children, whereas with caregivers, we had actually explained each of these criteria, whether it's appropriate, somewhat appropriate, etc. So if you look at children's satisfaction with latrines before and after, there is a significant difference in what children felt after we had done the alterations with the door lock as well as the door, and also inside the latrine when we reduced the space between the pan. So it was quite important for children, and you can see that children's satisfaction increased considerably. And caregivers' perception of the latrines appropriate for children improved as well before and after. Next slide, please. If you look at overall confidence that people had, the IDPs had about whether Save the Children would listen and act on their feedback, you'll see before and after there is a significant difference as well. So before this particular activity, they were not sure whether Save the Children would actually listen and act on their feedback. Then once we completed the modifications of the latrines and then went back and did the survey, there was a significant difference in the way they in the way they saw Save the Children, particularly in terms of acting on their feedback. So basic take home for us from this project is that it's fairly timely. So this whole methodology takes not more than 2.5 weeks to complete once it is started on the ground. So it's fairly quick. And second, you can actually tailor your interventions to help children and make it child friendly. So you're improving the quality of what you do with children in mind. And third, if you look at the caregiver's confidence, it also builds mutual trust, which is a core humanitarian standard, as well as something that we really, as humanitarian agencies have vouched for in the grand bargain. If you know what the grand bargain is, it's where the humanitarian agencies got together and say, we promise to do this, this, and this. And one of those things was the mutual trust relation. And this particular project helps that as well. Now, going forward, like I mentioned earlier, we're looking at how we can use this tool in two contexts. One is WASH in institutions, both in schools as well as health centers. Second is also look at using for other WASH activities and not just latrines. And going forward, in terms of future, we want to make this an open source with a web hub where anybody can use. And I'm not really sure at this point how adaptable it is for a development context, but I personally, having used these digital tools, I don't see a problem with it. It is just sitting down and making sure that we are able to adapt the tools and the methodology to a development context. Next, please. The second innovation that we tried, and I was not involved in this, so I'm kind of stepping in on this one, is the hidden incentive or the surprise soap idea. I think most of you would have heard about the Kinder Joy, which kids love to buy, and not because of what the chocolate is all about, but what is inside. So that was used as the idea. And with partnership with an organization called Field Ready and London School of Hygiene and Tropical Medicine, we together developed these soaps with 3D images, put some animals inside the soap, which called it hidden surprises. They were quite appealing in shapes, mostly animals, and the colors were quite bright as well. Next slide, please. So this was piloted in Iraq. The control group was where we gave normal soap that we distribute during an emergency, which is quite bland and not very colorful. And it's. I mean, I know what. I'm sure you'll know what I'm talking about. So it is a normal soap, but we also had an hygiene promotion activity that went along with it. So that was a control group. The intervention group is where we gave the surprise soaps, and no hygiene promotion was done at all. So there was a statistic analysis, and in the end, the results actually, in brief, showed that the intervention group, they were 4 times likely to wash their hands at critical times. And critical times is before eating food, before, after using a latrine, etc. So there was a significant difference, and there's 4 times more likely children wash their hands due to the surprise soaps. But this is just one pilot, and more are planned in the Horn of Africa. And if evidence does suggest, then it could be something that humanitarian agencies who, particularly like Save the Children, who works with children and do child hygiene kits as well, can use going forward. That brings to the end of my presentation. Happy to answer any questions, but if there are some that I can't, I will hand over to my friends or colleagues who may be able to do that. Thank you.
Thank you so much, Abraham and Steve, for those thought-provoking presentations. And I'd like us to take up the questions that are in the chat box and have a bit of a discussion around the questions you posed and the opportunities you see with these approaches. To facilitate the next discussion, I'll invite my colleague Salome um, to take it from here. Salome?
Hi, can you hear me?
Yes.
Hi,
Thank you.
thank you. Thanks, Mo. So really great presentations. I took so many notes, and I'll probably have a lot of follow-up questions probably on the side because it'll probably take up all the time. But I wanted to read a few of the questions that came in the chat box response. There was a question on children as caregivers, and how do you engage them through child-to-child approach? Is there another way that you're hypothesizing how to approach them? And then do you expect any changes in children's education from these interventions? So I'll give that to you, Stephen.
Yeah, thanks. I would say that in typical nutrition programs for children under the age of 2, we usually work through health extension workers, and I would say that they usually sort of mentor mothers and other caregivers through 2 main mechanisms. One, the healthcare extension workers do household visits to families with under 2 children, and they do like routine counseling on nutrition specific, but also nutrition sensitive, like WASH and agriculture messages or best practices that they want the caregivers um, to use during childcare. The other method is through mother care groups. So that's like more of a community setting where mothers come to a central place, and the health extension worker, or maybe in some cases like a program staff member or a government official, will counsel them, have them play games. They'll do cooking demonstrations so they can see what sort of recipes include the best nutritious and the most variety of foods for their children. And so the questions we've been grappling with are, should we actively try to include adolescent caregivers in these mother care groups or in the household counseling sessions? Because on the one hand, they're obviously caring for the children, and so they're very influential in the health and nutrition of those younger kids. But at the same time, we may be discouraging them from going back to school or encouraging their parents to keep them in the home because they're effective caregivers. So I don't have a straightforward answer, but those are the questions we've sort of been faced with, and we're still trying to work out how best to involve children as caregivers without having negative consequences. In terms of their education, um, it's something that we've considered looking at, but we haven't actually yet done any formal assessments before and after an intervention, mainly because of the first problem I was mentioning. We're unsure how to best approach the children, so we haven't yet intentionally involved them in these nutrition programs. So we haven't yet, since we haven't involved them, we haven't measured any changes in education yet.
Okay, thanks so much, Stephen. And I mean, I think those are fair points, right? And I want to encourage anyone on the line who may have worked in a similar situation, if they have any advice, to please chime in. I'll move on to the next question. Still with you, Stephen. It's in many countries, child marriage is still an issue. Were the implications of this training on encouraging child marriage considered?
Yeah, I think this is a really good question. Something that we've also been discussing, and it's quite related to my last response. Like I said, we haven't actually started doing any intentional programming around school children as caregivers, but I think this would be an extremely important thing to consider, to make sure that we weren't somehow encouraging or promoting early child marriage.
Of course. Thank you, Stephen. I appreciate that. Abraham, we're going to now switch on to you for some questions. One question is, why did you use a digital interface for the survey? And was it because it was a large population of students?
There are two reasons for it, Salome. One is it's fairly quick. So once you do the survey, you have the analysis and the results fairly quickly on a digital interface. Imagine using a questionnaire with paper and going back with the paper and putting it on an Excel sheet, spreadsheet, etc., and then analyzing the time it would take. So one is it's quite fast. The results come fairly quickly. And second is, of course, as you mentioned, the number of responses we can get will be much more than when you do a survey using a paper, for example.
Exactly. A follow-up question. Were there any unassumed challenges that came to using this in the field?
We did actually see some challenges. Some of them were a bit, especially in Ethiopia, where they're quite remote. The Somali region is quite remote, and people were a bit hesitant to touch it initially. So it took a bit of while to make them feel confident, and you had to actually get a child who is a much more braver person to start, and then the rest would follow. So the challenges were on the use of technology initially, but then once they started using it, everybody wanted to be part of it, actually.
Oh, that's wonderful to hear. Follow-up question. In what stages of a humanitarian program can realistically implement a user-centered approach to designing the sanitation facilities? For example, is it possible to use this approach in immediate response to an emergency?
But that's a very important question, and we've been trying to answer that ourselves as well. It is fairly easy to use this in a protracted crisis or a slow onset emergency. In a rapid onset, I think the first 2 months of a response, 2 to 3 months of a response, we should use this as a planning stage. And actually doing the survey would be maybe after the third month, because you have to have the team in place. You need to have the enumerators. You need to have the WASH team. They need to be trained using this. The digital platform has to be ready. The questionnaire needs to be ready, which takes about 2 weeks. So all in all, it takes about 1 month to prepare all this. But if you don't have a team to implement the activity, and if you don't have a team to actually do the survey, which is very difficult in the first 2 to 3 months, then you cannot do this. So ideally, I would guess that it is possible only after the third month. Does that answer your question?
Yes. Well, you actually answered a follow-up question as well. Thanks so much, Abraham. Well, those are the written questions, and you've answered questions that I have. I invite those folks on the phone to unmute yourselves and ask any questions that you might have while we still have time. We have about 20 more minutes in the session. We don't have to use it, but I would like to give folks an opportunity to chime in. Claire, I see
Hello.
you yourself.
Hi, can you hear me? I'm actually in a shop in the middle of London, so but I really wanted to attend this fascinating webinar. It's Claire from Children for Health, by the way, and I spent about a decade working with Child to Child. Obviously, these questions that were raised are questions we've been grappling with really for many, many years. And I wondered how far you've managed to get with trying to engage with the research departments to help start to address some of these important questions. There seems to be a lot of interest when I, for example, talk to the London School of Hygiene and Tropical Medicine, but I haven't been able to get a research project to actually land yet, which is a dream of mine. Thanks.
Thanks so much for your question. Stephen?
Yeah, I think we're in the exact same situation. You know, before we start designing such a program, I think there's so many very sensitive topics we need to address that we've been very cautious, you know, in terms of designing or implementing or approaching children as caregivers. And so we would very much like to do some research first, but it's been very difficult, at least through these nutrition programs, for them to focus or invest in research in this space because they have, you know, a long list of very technical research questions that they want to answer in the nutrition and nutrition sensitive space. And so this like cross-cutting issue of child caregivers hasn't really been a priority for donors in terms of research, but it's good to know that you said you're at the London School?
Yes, I believe that's what she said.
Okay. Yeah, it's good to know that there's research institutions like the London School who are also interested that we could reach out to if we're able to secure some funds for something like this.
I'm not at the London School. No, I run this independent NGO, but I've got quite a lot of contacts with the London School and also with a couple of other university departments.
Okay, I see. Great. Yeah, thanks. Sorry, I don't have a good answer for your question.
Thanks, Stephen. I think it's still very promising to know that there is interest in other locations, and potentially if we can expand our networks to try to work together, we might be able to answer some of them. Doug had raised his hand to ask a question. Doug, please unmute yourself.
Yes, thank you. And it's my work has been primarily in high resource countries, but I'm quite intrigued with the surprise soap technology. And as the grandfather of two young granddaughters, who's always a struggle to get them to wash their hands and brush their teeth. It's I wonder if there's been consideration to using that technology in high resource countries, maybe even as a way of generating some funding for programs in lower resource countries. I think it would be possible for school systems in those high resource countries to be able to purchase that kind of soap for their washrooms, and certainly knowing my two granddaughters, it would be certainly an encouragement. They do like to have little toys associated with their food and with their daily life.
Thanks,
So
Doug. Sorry.
Go ahead, Abraham.
Thanks, Doug. That's an excellent suggestion, actually, to raise some funds to do it. We are having a meeting with Unilever next couple of weeks later, actually. So we had a plan to present this project to them, but I'm not really sure whether they will take it or not. Something that they would want to do with their Lifebuoy or any of those products. But it's a really good point. And in terms of raising funds to do these projects further, we are also looking. These soaps are actually prepared locally. As of now, the cost is fairly high. It's between $2.5 to $3.2 for each soap, because the technology and all the resources coming in. But if we get the buy-in from individual countries, then it becomes really cheap. And if you can find a private supplier, it becomes very cheap and doable. Does that answer your question?
Doug, you can unmute yourself.
Sir, thank you very much. Yes, good answer. Thanks.
Thank you. Are there any other questions? I see we have a fair number of people. I'm still on the line. I'll give it a few more minutes. While we're waiting, I just want to thank our presenters again. This is really, really fascinating work, both the theory behind the new approach and also the potential of using this user-centered approach, not only in WASH work, but in other thematic areas. So thank you again. I know I will be in touch, hopefully, and I encourage everyone else. Let me go back just to ensure that everybody has seen the email addresses, just so this is for Abraham if anyone wants to take that down. And I believe we'll send that in email as well. Let's see. Yes, Claire, I see your response. Just to answer, we did hear you. We heard that you didn't work for the London School, but worked for an individual NGO. Thank you. But it's still good to know that agencies and research institutions like the London School are interested. Thank you again. A question came from Yanita that says, have you ever evaluated the potential environmental impact of including a plastic product in a daily item such as soap? And are there alternatives to a plastic toy? Abram, that's for you.
Good question. Actually, we started discussing about it after Greta said what she had to say at the UN. So we are looking at that. We're looking at options of not having plastic, and with Field Ready as well as London School of Tropical Hygiene Medicine, we're trying to get some alternatives to plastic. Thanks very much for reinforcing that to us.
Thank you. It's great question. Let's see. Claire gave a comment saying that my feeling is that if children are recognized and praised for their role as caregivers, then their caregiving is really beneficial. And that's definitely one of the pros to this approach, and it's definitely empowering. And it does have, though not necessarily research at the given moment, potential implications for that as well. So thank you for bringing up a positive of this approach. Does one caregiving is expected and not recognized that is exploitative? Exactly. We couldn't agree more. Are there any other questions while we still have our presenters on the line? Let's give another minute or two. Okay. Looks like I think we've answered most of the questions. Not to belabor this wonderful presentation. Thank you again to both our presenters for your wealth of information and sharing all of these opportunities. We will share this recording slide deck that comes with it with a listserv. And we thank you all for your time and wish you a fantastic day, whichever your time zone is. Thanks so much.
Thank you.
Thank you, Salome, and thank you, Steve and Abraham. I just wanted to also announce that this is our last webinar for 2019. The next series, the 2020 series for Fresh Webinars, will resume on the date closest or on the 15th of February 2020. It'll be most likely the 18th. 15th is a Saturday. And we'll be putting together a list of webinar topics and presenters, and we'd love to hear from our community of listeners. If they'd like to share their work, please do reach out to me or any of the Fresh members and that you're linked with your presentation ideas, and we'll be in touch in the new year. Have a good rest of day and weekend, and thank you very much.
Thank you, Mo.
Thank you.
Thank you. Bye-bye.
Bye-bye.